Howdy, good morning, everyone. It is 10:33 on a beautiful Saturday, September 28th. This is Aaron Boster from the Boster Center for Multiple Sclerosis. Super excited to kick off the September live stream. Do me a favor and let me know how the sound is coming in. Are you guys able to hear me okay? Just let me know in the chat if the sound is working out all right. As you guys jump online, as always, please tell me where you're jumping in from. Let me know where you're calling in from. It's amazing to go back through this chat and to read where everyone is amassed from. It's absolutely amazing. I'm getting feedback that you guys can hear me okay. That's fantastic. We've got one of our fantastic moderators already online. Let's welcome Ben. Ben, thank you for helping out today. Sorcha, it's great to see you. Benita, it's great to see you. Judy Lemare, I hope that you're doing well. This is fantastic, guys. Thank you so much for joining me today. We're going to go live at the top of the hour, so in about 25 short minutes. And today I have a few things planned for you. I'm excited, of course, to do our standard Ask Me Anything Multiple Sclerosis. I simply request that you make your questions generalizable. I can't provide specific details to help diagnose or to treat you over the interwebs, but I can certainly provide education with the goal of energizing and empowering you. I'm also excited to share with you some hot off the presses data from two clinical trials that were just presented at the ECTRIMS conference looking at tolobrutinib, one of the new and exciting BTK inhibitors. So I'll be excited to share that data with you. In the meantime, as we get ourselves ready for the 11 o'clock go live, please make yourself comfy and cozy, jump online, introduce yourself, tell us where you're logging in from, and say hello to someone in the chat. I am delighted you guys are here and can't wait for 11 o'clock. Joe Siders is in the house, one of our amazing moderators and a hell of a good guy. Joe, it's great to see you. Thank you for being here and helping out. Look at all these wonderful folks jumping online. We've got Germany in the house and Dallas is represented. We've got London in the house. We've got Georgia in the house. This is fantastic. And Sorka, I keep mispronouncing your name and I feel terrible for that. I apologize to you. Sorka. Okay, I'm going to practice that. I certainly am not trying to say it incorrectly. Welcome, everyone. Thank you for being here. LL says the audio is low. Are you guys having trouble hearing me? Testing 1, 2, 3, 4. Mary had a little lamb. Welcome, everyone. There's almost 100 of you that have jumped online already, and that is fantastic. Thank you for being here. Thank you for joining me for the Boster Center September live stream. We've got another wonderful moderator who has just jumped online. Hello, Angela. I hope that you're doing well. Try turning up your audio all the way. I've got mine tweaked up on my microphone, and I'm hopeful that you guys can hear me okay. Some people think that the audio is fine. Some think it's a bit low. I wished that I had more technical savvy. I don't know how to turn it up any higher, guys. Kelly is in the house. We've got unusual numb limbs. This is fantastic. Thank you all for being here. Save your questions for the 11 o'clock go live. We've got Canada in the house. Where's everyone coming in from today? Welcome, welcome, welcome. Welcome, Kathy. Welcome, Dominic. Welcome, Javin Cincy. Great to see everyone this morning. Good morning, Sherry in Michigan, and hello, AC in Romania. London is in the house. Miss Boyle is in the house. We've got Helen, who's here from Massachusetts. Grove City is in the house with Terry G. Terry, I hope you're doing well. Ben is leading the way. He knows what's coming. We're going to flame up the chat just before we go live at 11. Sanders in the house representing Virginia Beach. Let's see here. I just threw a poll in the chat. If you have a second, go ahead and click your answer. I'm looking forward to doing a presentation on one of the BTK inhibitors, but I want to make sure that sounds good to all of you. Joe Siders, one of our amazing moderators, is reminding us that you can sign up for the Boster Corner. This is a monthly newsletter. It's free to you, telling you the latest and greatest at the Boster Center for Multiple Sclerosis. It also tells you when we're going to go live every month so that you don't miss any of these live streams. Bluthton is in the house, one of our amazing moderators. Thank you for being here. Slade representing East Oregon. Welcome, welcome. We're going to be going live at the top of the hour. All right, JV Cincy coming at you. J. Vincenzi, working on that. We're going to go live in 20 short minutes. I can't wait to launch this Ask Me Anything live stream. It is a beautiful September day out. I'm so excited to be here with you guys. There's 107 of you that have already jumped online. Wow, that's amazing. Thank you all for being here. This is our September live stream. I'll be answering your MS questions live, and as long as there's enough interest from the polling question, I am prepared to give you a didactic lecture on some recently published data, or recently presented data on one of the BTK inhibitors in multiple sclerosis. So stay tuned. I'm going to mute my mic and grab some water for the MS Water Challenge and another cup of coffee, and I'll be back with you guys shortly. Make yourself comfortable. Please do exactly what Veronica did, sharing where she's logging in from. We've got folks from Serbia in the house. We've got the Jersey Shore represented. We've got Massachusetts represented. This is fantastic. Welcome, every one of you. Welcome, welcome, welcome. Howdy, hi everyone. Aaron Boster here. I'm back. Just got some water and some fresh coffee. Super excited to go live in 12 short minutes at the top of the hour. If you haven't had a chance to answer the polling question, please take a hot moment and do so. I'm excited to share with you some data about the recently presented BTK inhibitor, tolebrutinib. It looks like 94% of you are on the same page. I'm super excited about that. As you jump online, please share where you're jumping in from. It's awesome to see where this growing global online community has amassed from. Robert Wilhelm is in the house. Hello, Bob. It's great to see you. Lisa's representing Mississippi. We've got Janice from Florida. Thank you so much for being here. Naples is in the house. Jason Bell, it's great to see you, my friend. Susan from Alabama representing. Massachusetts is in the house. St. Louis is here with Kat. Valentin throwing up some explosions. I love that. Getting ready to go live in 10 short minutes. We've got the UK in the house. Massachusetts up in this place. We've got Nevada representing. Welcome, welcome. Carl from Utah is here. John representing Jersey City in New Jersey. Fantastic. Jason's representing and doing a parents' weekend. That's super fun. I hope that you guys are having a great weekend. Welcome, Paula in Muskegon, Michigan. Thank you all for being here. There's 118 of you. That's unbelievable. I am just overwhelmed. This is so cool, guys. Thank you so much for being here. I am thrilled that we're going to get a chance to connect today. Jay is representing India. Welcome. A Pepper's in the house. It's great to see you here today. Looking even more forward to seeing you in person very, very soon. Larry's in the house representing Hamilton, Ohio. This is fantastic. John, it is great to see you today. Finland is in the house. That's amazing. Welcome, welcome. What time is it in Finland right now, guys? 120 of you have jumped online. This is really starting to heat up. Thank you so much for being here. We're going to go live in 9 short minutes. Paris from California is in the house. We've got Scotland representing. It's 6 p.m. in Finland. It's almost 11 a.m. here in sunny Columbus, Ohio. We've got Sermon representing Pennsylvania. Welcome. Welcome, Mary from Washington State. Scotland is in the house. This is unbelievable. Welcome, everybody. As you jump online, of course, share where you're jumping in from. This is Aaron Boster from the Boster Center for Multiple Sclerosis. We're about to kick off our September live stream where I answer your Ask Me Anything MS questions on the fly, on the spot, live. And today I've prepared a didactic lecture. I'm going to be sharing some information about the recently presented tolebrutinib trials. Denver, Colorado in the house. We've got Chicago, Illinois representing. Bonita screaming, go Bucks. There's going to be a lot of that going on this weekend, I'm sure. Knoxville, Tennessee is in the house. Welcome, everyone. There's 140 of you online. This might be a record for the largest number of people that have been here when we kick it off. British Columbia is in the house. It's 8 a.m. in British Columbia. Welcome, MS Babes 77. I've got my coffee in hand, water at the ready. We're going to go live in 7 short minutes. Chris is about to celebrate his 12th year anniversary since time of diagnosis. Thank you for being here. Georgia's in the house cleaning up after Ellen. I hope that everything's okay down there. John, I have people from New Jersey that fly into the Boster Center twice a year to receive care. Not a small number, actually. Doug is in the house, one of our amazing moderators with coffee in hand. Doug, I've got my coffee right here, partner. Asking questions about trigeminal neuralgia. Joe Sider's leading the way, our amazing moderator, reminding you that very soon it's time to start to flame up the chat. We're going to flame up the chat right as it gets close to 11 o'clock when we go live. Scotland is in the house. MS Reef, thank you for being here. Puerto Rico representing. We've got Ben in the house showing flames. That's fantastic. Thank you, guys. We're about to kick it off in 5 short minutes. Now's the chance to go to the bathroom if you need a bio break. We've got Tucson, Arizona representing. Good morning, Kathy. I hope your weather is outstanding out there. Welcome, welcome, welcome. Joe Siders is at the ready. You got all the things that you need. I'm digging it. Colombia's in the house. John Jenkins showing up flames. Bonita is showing flames. We go live in 5 short minutes, guys. This is the September live stream, Ask Me Anything MS, with an added didactic lecture on the newly presented tolobrutinib data. Excited to share that with you. Avery Pape is in the house. Rhonda here, she says, dodging raindrops in Columbus. Outstanding. Jerry Burns is in the house. Hello, my friend. It's good to see you. Catherine's in the house. We've got 4 minutes until it's time to go live. You know how we do it. Get ready to flame up the chat. Miss Torres is in the house. Good morning to you. Judy in St. Louis is in the house. Hello, Ann. Welcome, welcome. 3 minutes until we go live. There's 155 of you that have saw fit to jump online. Thank you to each and every one of you. It's time to flame up the chat. Do like Judy has done. Show some love in the chat. Flame it up. This teaches the YouTube algorithm that you are pumped for what we're about to do together and helps push this content out so more families impacted by MS can benefit. Do me a favor and let's get that entire chat flamed up. Let's get ready to rock and roll. Ben is leading the way. Phi Right has the right idea. Dina is showing love. Entropy Freedom is showing love. Grandma Sally is in the house showing flames galore. Paris has got the right idea. You know what to do, guys. Flame up the chat. Let's get the whole thing flamed up. We've got J. Vin Cincy up in this house doing it right. Thank you all. Thank you all. Tina showing love. Rhonda showing love. This is fantastic. We have 2 minutes until we go live and we flame up the chat to show the YouTube algorithm that we like this content and help more families impacted by MS benefit from education, empowerment, and of course, energizing. Everybody, let's do this together today. It's 2 minutes until the top of the hour. There's 162 of you that have gone on live already. This is phenomenal. Thank you so very, very much. Thank you, Kat. Thank you, Carl. Thank you, Robin. Thank you, Nanny, showing onions. I love that. Beth R. has the right idea. Flame up the chat, guys. We have 2 short minutes until we go live. You know how we do it here at the Boster Center live stream. This is the September live stream about to kick off in 2 short minutes. Don't stop the flames, guys. Bonita's got the right idea. Rebecca's got the right idea. 1 minute until we go live. I can't stand it. I'm so pumped. Walter's in the house. MS Reef says it's getting hot in here, and that is exactly right. We're about to go live in 1 minute. I can hear the drum roll in the background. I see the flames. Kelly flaming it up. Beth flaming it up. John flaming it up. Grace flaming it up. Paris flaming it up. This is fantastic. Judy Lemaire, you've got the right idea. No worries at all. Angela and Grandma Sally is in the house. We have literally less than 60 seconds until we go live with today's Ask Me Anything live stream. This is Aaron Boster, pumped to be here with you, as 168 of you have already jumped online. Wowzers. That is phenomenal. Slade is in the house showing flames. We have seconds to go. It's on. Hi! Good morning, everybody. Aaron Boster here, coming to you live from Columbus, Ohio, representing the Boster Center for Multiple Sclerosis, and this is our September live stream. I am so excited to be here with you today, and I have to tell you, since the Boster Center opened its doors in March of 2020, we've been doing some form of monthly live stream to help amass this growing global online village and help empower, energize, and educate families impacted by MS. Now, I'd like to turn the set on about a half an hour early to give you time to get comfy cozy, to get your beverages at the ready, so we can go live at the top of the hour. And I have never seen this many people waiting, 175 of you. Thank you to each and every one of you. That is really, really special. Today, I have two things planned on the docket. The first, of course, is our standard Ask Me Anything live stream, where you ask questions about MS and I do my very best at trying to answer them live and impromptu. I also am very, very excited to bring to you today a didactic lecture, a little education on something that I've been very, very involved in, and that's the development of BTK inhibitors for multiple sclerosis. Last week was the International ECTRIMS Congress, and at the ECTRIMS Congress, we saw the very first presentations about one of these medications. I'll be very excited to share with you that information. Now, Len Mays is saying that my microphone is low. I want to make sure that's not the case for everyone who's listening in. Please let me know if you're able to hear me okay. To be transparent, I'm not sure how to turn my microphone up. I'm not terribly adept at this interweb stuff, but I'm hopeful that you guys are able to hear me. Even so, it as well, one of our amazing moderators is on the line, and thank you for being here today to help out with the chat. Let's kick things off by answering some Ask Me Anything questions. So if there's a question about MS, please phrase it in a generalizable way. I can't diagnose or treat you over the interwebs here, but I can answer your questions as long as they're generalizable. So let's throw those questions in the chat, and we'll take a few of them to kick the hour off. Got my coffee at the ready, just like Doug Tagg. That is delicious. Sometimes I go to bed at night excited that I'm going to be able to wake up and have a cup of coffee. All right, so let's see. We've got a question coming here. So Jen Mack asks the first question of the day. She says, I'm starting Spnamod in just over a week. I'll be in an observation first dose. Any tips? So Spnamod is in a class of medicines which are called S1P1 receptors, or actually called receptor modulators. That's like a lot of words. They are pills that are taken once daily, and the first drug in the class came out in 2010, which is quite some time ago now. And that drug was Gilenya. And since Gilenya has come to market, there's been several other Me Too drugs, second generation S1P1 receptors. Spnamod is one of those drugs. These are moderately effective medicines. I like them. I think that they're very, very good. Particularly, I think they're very good at decreasing relapse rate and decreasing new MRI lesions. They do a decent job at slowing brain volume loss. I don't love their disability data. It's not horrible. It's just not outstanding. and they're very, very well tolerated. So the question is, any tips for the first dose? The first dose phenomenon is really interesting because when you take this class of medicine, some of them can drop your heart rate a little, not a lot, just a little. And to make sure that there's no cardiac concerns, sometimes we'll observe the person for half a day to make sure that their heart rate doesn't go too slow. Now, a couple things which are very relevant to the first dose monitoring. The low heart rate is adjustable by coffee. And so if someone has a low heart rate, you can simply have them drink a cup of Java, or you could actually have them do like some jumping jacks because that will raise the heart rate as well. I don't think there's anything in specific that you need to do to prepare for the first dose monitoring. I will assume that all of the pre-testing has been done ahead of time and that you're going to have a relatively easy breezy half day at the center getting yourself ready to take that medicine. Excellent question, and thank you for asking. Let's take another question from the chat. This is Kelly Knight, who writes, changing from one DMT to another, thoughts, challenges? So that's a very, very generalized question. As I count, there's 27 different formulations of MS medicines that are now approved by the American FDA. And honestly, Kelly, in order to answer that question, I need to know two pieces of information, maybe three. I need to know what drug you are on and which one you're switching to. And then I also need to know what other medicines you've been on in the past. And with those pieces of information, I can normally help you carve a path to transition from drug A to drug B. But without those pieces of information, it's going to be very, very hard to take that a little bit further. Tessa Broad shares Limtrada second round, very nervous. And so it's no secret on this channel that I am a big proponent of using Limtrada in the right patient population. I find it to be the single most effective disease-modifying therapy that I've used in my practice, which is now just about 20 years. Limtrada is a very unusual drug. It's a drug given IV in the vein, and it's given for 5 consecutive days the first year. So Monday, Tuesday, Wednesday, Thursday, Friday. And then there's no treatment for an entire year, which is really weird, but kind of cool. And then you do 3 days. So when she says Limtrada second round, my assumption is that we've done the 5 days, we've waited a year, and now it's time to re-up for the 3 days. So a piece of information that I find reassuring, when you have your first 5 days of Limtrada, it's brand new to your body, and your immune system is not used to seeing the Limtrada drug in your body, and it's not used to seeing the aftermath of Limtrada blowing up your B and T cells and spilling the guts of your B and T cells in your bloodstream. The very first time that your immune system sees the inside of the B and T cells, it doesn't like it, and you can have all kinds of infusion reactions. However, the second year, when you go back to have the 3 days, your body has already seen those cells. It's already seen the inside of the B and T cells. It's already seen Limtrada. And your likelihood of having an infusion reaction is much lower. Now, I've given a lot of people many, many rounds of Limtrada. I typically will cap out at 4 rounds. And consistently, round 2 is better tolerated than round 1. Consistently, round 3 is tolerated better than round 2, almost without exception. So whereas I think it's fair to be a little bit anxious and apprehensive as you're getting ready to do something as intense as chemotherapeutic induction, it's a lot of words, but I'm really pleased to share that our expectations are that it will be less of a to-do this time as compared to the first 5 days. And I wish you the very best of luck. You're going to be awesome sauce. Let's take another question from the chat after I have a sip of Java. Here's a question from DTR of the King, who writes, do you ever use Klonopin for a muscle relaxer? No, not if I can avoid it. So spasticity is very, very common in the setting of MS. And I have many, many YouTube videos on this channel talking about how to game out treating spasticity. And oftentimes, to be successful treating spasticity, we have to use medicines, lotions, and potions to help the muscles relax. There are a host of drugs that we can use, and Klonopin is a benzodiazepine. So Klonopin is in the family of Valium, and it has antispasmodic properties. So you can use Klonopin, to help with treating spasticity, but I try to avoid it as much as I can. Why? Benzodiazepines have a tolerance, meaning when you take them for a while, your body can get used to them, and then you need to take more to have an effect. And benzodiazepines can have a dependence, meaning when you stop them, you can go through a withdrawal syndrome. And so, because of that side effect profile, I try to avoid benzodiazepines. I use medicines like baclofen and Xanaflex before I use Klonopin because I like the side effect profile better. Now, does that mean that it's naughty to use Klonopin to treat spasticity? I don't think it's naughty. I just think that it's a little bit more risky and a little bit more complex. Have I ever done it? Yeah, I have done it with some patients, have specific situations where other medicines didn't work, but I really do, in fact, try to avoid it just to avoid the tolerance and dependence concerns. Also, I have helped a bunch of patients over the years successfully stop Klonopin. And oftentimes, patients and clinicians will have some frustrations and challenges, difficulties coming off of Klonopin because there's such a significant withdrawal syndrome. My secret sauce is to go really, really slow. When I say really slow, I'm talking about making a small change for a month and then another small change for a month. So let's pretend that someone started off taking Klonopin 1 milligram every night, which is a really large amount. So we might start by having them take 1 milligram on Monday, and then on Tuesday take, say, like 0.75 milligrams, and then on Wednesday go back to 1 milligram. So we'll alternate 1 milligram, 0.75, 1 milligram, 0.75 every other day for an entire month. Then on month 2, we'll drop down to 0.75 every night. In using this very, very slow monthly decrease, I've been successful getting people off Klonopin over a period of, say, about 6 months. Now, that's a lot slower than what's normally done, but I have great success in doing it without withdrawal. That was a great question. Thank you for asking. I noticed someone said something very nice in the chat. Jenny B said, love the specs, and thank you for that. These are brand new glasses. I had my old pair of glasses for over 20 years. And they had become so terribly scratched that it was super, super hard to see. And so I'm really excited that I have a new pair of glasses. And I have to tell you a quick funny story. When I went to see I thought he was like a 12-year-old optometrist, a very nice young man, but really young. And he was doing my eye exam and he said, wow, do you have bifocals? And I said, no. And he said, well, do you spend a lot of time doing this when you're trying to read? And I said, yeah, all day long. So I asked him, I said, should I get bifocals? And he goes, not if you don't mind doing this. What's funny is on the prescription, he actually put in bifocals. So these are bifocals, and I've spent all week trying to get used to them. For those of you that are not familiar with bifocals, walking downstairs is very, very challenging. So Jerry Burns shares that he's looking forward to the second round of Lemtrada and just did the 6-month blood work and everything looks awesome. And that's fantastic to hear, and congratulations. So here's a question on the theme of spasticity, and this is from Brianna Moskro, who writes, hey doc, well hello. What tips do you have for spasticity and muscle tightness for pregnant women? So this is a very common phenomenon. The majority of people with MS are women of childbearing potential, and there's lots of pregnancies in the MS clinic, which is always very, very exciting. But we also have to grapple with the fact that most people impacted by MS take 7 medicines on a day, on average. And many of those medicines might not be safe in the setting of pregnancy. So what do? Well, the first thing is I like to have a conversation with the obstetrician gynecologist. And I like to ask them their level of comfort with the various medicines. As a non-obstetrician, when a patient of mine is pregnant, I want to remove anything that's dangerous because I don't want to do anything to potentially hurt the pregnancy. I have found that obstetricians are oftentimes very, very comfortable, more comfortable than I am, saying, oh, that one's okay to stay on, that one's okay to stay on. And so we first want to check in with the OB-GYN to find out what is a no-no drug and what might we continue with. Now, Oftentimes we do have to do things like come off of the baclofen and come off of the Xanaflex, and that is very, very challenging because that can make spasticity much worse. So what are some tricks and tips? One tip is I want you to become a master of stretching because stretching helps decrease cramps, spasms, and stiff legs for a few hours. And stretching is free. And so oftentimes we will have someone stretch in the morning when they wake up. We will have them stretch in the middle of their day and then before they go to bed at night. And that can ratchet down the spasticity. Sometimes, of course, this is not adequate, and we do have to hope that the OB-GYN is comfortable using low doses of baclofen. It's also relevant that as you go past the first trimester, so after the first trimester, the baby has made all of the organs. So you're done with what's called organogenesis. And then second and third trimester, we're just growing those organs. So drugs that are less safe in the first trimester are sometimes okay to use in the second and the third trimester. That's a great question, and I appreciate you asking it. All right, let's take another question from the audience before we jump into this didactic session. Here is a question from Beth R. Can sarcoidosis be confused with MOGAD because of the optic neuritis? Now that's a very, very intelligent question. It's a very complex question, and I'm looking forward to answering it. But first, MS water challenge, yo. When I drink, you drink. You know how this works? Drinking water is massively underappreciated in culture in general, and in specific in families impacted by MS. We have found time and time again, when you up your water game, it can really decrease a lot of symptoms. Even spasticity that we were just talking about is better managed when someone is adequately hydrated. So that's the MS water game. When I drink, you drink. Thank you, guys. Now, let's go to one more question. So Melissa asks the question, I forgot about the neurosarcoid question. Shame on me. So I don't know where the question went, but the question was, how do you tell the difference between sarcoidosis and MOGAD because of the optic neuritis? So let me back up a couple thoughts here. When a human has a symptom, it doesn't come with an answer key. So when you experience an optic neuritis and you have trouble seeing out of your eye and it hurts when you move your eye, and you go to see the ophthalmologist and they look in the back of your eye and they say, oh my gosh, it's all swollen, you have an optic neuritis. We then have to figure out what the optic neuritis was from, because many different conditions can cause optic neuritis. Things like multiple sclerosis, things like MOGAD that the question was about, and MOGAD or MOG is a cousin of multiple sclerosis, a demyelinating condition which affects optic nerve and spinal cord. It could be caused by neuromyelitis optica spectrum disorder, another cousin of multiple sclerosis. It can be caused by sarcoidosis, which was part of the question. In fact, there's a bunch of different conditions which could cause an optic neuritis. So if you think of the optic neuritis as a symptom, we then try to figure out what caused the symptom. And we oftentimes do that by doing further testing. We'll send antibody tests to look for MOG. We'll send blood antibody tests to look for NMO. We'll do chest CTs to look for neurosarcoid. And importantly, we'll do neuroimaging. So we'll image the brain and the spinal cord to look for a pattern on those scans, which teach us which condition we're talking about. So this is a very, very common diagnostic situation where someone presents and they have an optic neuritis, and the question on the table is, what's caused it? Thank you for asking that question, and thank you to the 228 of you that have jumped online. That's amazing. Thank you very, very much. Now the question that's on the board. Melissa asks, hi doc, well, hello, been on Tysabri for 10 years. Can it be switched to Kesimpta? And the answer is yes. So Tysabri is a highly effective drug. It is an infusion in the vein, typically given either every 4 or every 5 or 6 weeks for life. It's a fast infusion and very well tolerated, generally speaking. I've had great success using Tysabri in my practice. Kesimpta is a much newer drug, having come out, I believe, in 2022-ish or 2023. It's not been out for very long at all. And Kesimpta is a self-injected shot that you take once a month. It's a B-cell depleter. And it's also a highly effective medicine. And so in my mind, going from Tysabri to Kesimpta is a lateral move. We're not really sacrificing any efficacy when we do that. And in fact, the Kesimpta data on brain volume might be slightly more impressive than the data on Tysabri. The question really is, how do you make that transition? And this is a transition that I've helped patients do before, and it's actually not very hard. Tysabri does not last in the body very long. So when you stop Tysabri, it's mostly going to be completely out of your system in about 2 to 3 months. And we don't want to wait until we wash out the Tysabri. That would be a mistake in my opinion. Because if we wait a couple months, we're allowing your naughty autoreactive cells that are in the bloodstream to get back into the brain and beat it up. And we don't want to do that. So what I like to do is, let's say we give you Tysabri January 1st. On February 1st, we're not going to give you more Tysabri. We're going to give you your first Kesimpta loading dose. When you start Kesimpta, you take a shot, and then 2 weeks later, and then 2 weeks later. So it's 3 shots in that first month to load you. And I would do that literally the month after we stop Tysabri. So I would almost be overlapping them. That way, the Kesimpta is up and running, working to deplete your B cells as the Tysabri is wearing off. So when the Tysabri is no longer effective and that Great Wall of China has been removed, now the B cells have been depleted and we're not going to see an uptick of disease activity. That's a great question. One caveat, one thing that I think is important is there is a risk of PML with Tysabri. And when we transition from Tysabri to anything else, I think it's a best practice to get an MRI when we leave Tysabri so that we can look at the scan to make sure that we're not seeing any trappings of PML radiologically. That helps us feel more confident when we start the Kesimpta. Now, I have friends in Great Britain who are MS doctors, and they actually will do a lumbar puncture when they stop Tysabri to look at the JC virus in the CSF and make sure it's not there. That way they can feel 100% confident that they're going to be able to transition. I don't do that practice. I feel more comfortable just doing the MRI, and most of my American patients are disinclined to sign up for extra lumbar punctures. There's 250 of you that have jumped online. That is phenomenal. I'm going to change the scene up. I created this purple scene, my favorite color. And so let's use this scene for a question or two before we jump into the didactic lecture. Let's take a look here. So this is a great question. And this question comes from Nova80. So Nova80 writes, I have a herniated disc in my lower back, roughly where I have an MS lesion. In April, I got my Ocrevus. Everything got better, but my legs didn't. Could there be a connection? I have lower back pain often. Now, the reason that I really like this question, Nova, is sometimes nature's too generous. And herniated discs that push and can smush the spinal cord or the nerves coming out of the spinal cord are common. That's a very common thing for us to see. I want to make sure that the music's not too loud. And in the setting of MS, sometimes nature's too generous, and you can have multiple sclerosis, which affects the spinal cord. And in addition, you can have a herniated disc. And that creates a diagnostic problem, because if my patient with MS, who also has a herniated disc, has back pain and leg weakness, I don't necessarily know, is that caused by the MS or is that caused by the herniated disc? So what do we do? Well, fortunately, the friendly neighborhood neurosurgeon can fix the herniated disc. They can go in and pluck it out, and they can fuse the two bones, and they can remove the problem. And oftentimes, I ask for that to happen because it's curable and it removes a variable off the table. So now, if you're having weakness or pain or numbness, I know it's only from the MS. This is remarkably common. And what I do when I'm doing an MRI and I see a herniated disc is I will send the patient to a neurosurgeon, not to have surgery, but just so that they can use surgical eyeballs to look at the MRI and tell us, no, you don't need to do anything, or actually, we probably should pluck that one out. That's a great question, and I appreciate you asking it. All right. We've been talking now for just shy of a half an hour, and I'm going to transition to the didactic lecture that I've prepared for you. And so I'm really excited to talk about this today. And what you see on the board here are some slides that were presented at ECTRIMS. ECTRIMS is the yearly international MS meeting. It's absolutely amazing. I'm very sad that this year I was not able to attend ECTRIMS. With my busy practice, I was unable to get away, much to my chagrin, and I sincerely hope that I'm able to go next year, because going to ECTRIMS is like the Olympics of multiple sclerosis. Now, at ECTRIMS, I was very delighted to learn that there was a presentation, which I'm going to be sharing with you right now, looking at one of the BTK inhibitors, which has been studied to treat multiple sclerosis. Now, a couple things that I want to share. These slides I borrowed from someone who is attending the lecture, and so I borrow them so that I can share them with you right now. I also want to share as a disclosure that I am an investigator studying this medicine, but the information I'm presenting is public, and I'm not sharing anything that's not found in the public domain. So there's no proprietary information that I'm sharing. This is all stuff that you could actually find on the internet, and I'm delighted to share it with you today. So with that background, let's talk a little bit about what you see on the board. And I want to direct your attention to that crazy word, tolobrutinib. So tolobrutinib is a BTK inhibitor. It's an investigational medicine. It's a pill, and it's a pill that has been used in other settings to treat things like cancer. And it's been recently studied extensively in the setting of multiple sclerosis. Now, there are two clinical trials that I'll be talking about today. The first is actually sister clinical trials called Gemini 1 and Gemini 2. And at the Boster Center for Multiple Sclerosis, I'm very proud that we enrolled patients into Gemini 1 and Gemini 2. And in this clinical trial, we enrolled patients that have relapsing remitting multiple sclerosis. So these are people with MS who have relapses. And in the clinical trial, all the people in the trial were given medicines. They were either given Aubagio, which is a standard of care medicine that you can actually prescribe to treat MS, or they were given tolobrutinib. And they didn't know which one they were on. And I didn't know which one they were on. It's called double blind. So neither of us knew which was which pill. Now, nobody was on dummy drugs, so nobody was on placebo in this trial. Everybody was on a real drug. It was either tolobrutinib or it was Aubagio. And the trial went on for many, many years, 3 years on average. And during that time, we measured the frequency of MS attacks. So how often did people have attacks? We measured the MRI, and we measured disability progression. And so I'm going to be presenting all that data to you. And so as we go through this, let's see here. This is the first slide that I want to share with you, and this is looking at the annualized relapse rate. And so what you see here in the purple are the people that were treated with tolobrutinib, all right? And so there were actually 486 humans with relapsing MS that were randomized, blinded, to be taking tolobrutinib, the BTK inhibitor. And then in the gray, we see people that were taking the Aubagio. That's teriflunomide, is the long name for Aubagio. And these two graphs, this is the Gemini 1 trial, so this was a clinical trial. This was a separate identical clinical trial. And if you look way over here, these are the two trials combined. And what we found was the people in the trial that were taking tolobrutinib had very, very few MS attacks, like one attack every 8 or 9 years, a very, very low annualized relapse rate. So you see that number 0.12. That's the annualized relapse rate, and that's a very, very low number. That's actually some of the best relapse data that we could possibly see. What's really weird, cool, and interesting and confusing, however, is if you look at the Aubagio arm, the gray bar, they had the exact same annualized relapse rate. So the people in the trial that were blinded but taking Aubagio also had a very, very low relapse rate. And as a result, this was a negative trial. We were unable to show that the tolobrutinib did any better than Aubagio at decreasing relapses. And so this was a complete negative result. That's not the only thing that was looked at, of course, because there's a bunch more data to share. Now, this is looking at not relapses, but disability progression. What does disability progression mean? It means that the human being was evaluated at the beginning of the trial, And later in the trial, their examination worsened. They developed neurological worsening. And that neurological worsening persisted for at least 6 months. So that's what they mean by confirmed disability worsening. The person got worse and stayed worse 6 months later. And what you see here in this graph on the x-axis on the bottom where it says months, so that's time. So as you go from left to right, you get older. And on the y-axis going up, as you go up, you become more disabled. And so as you look at the data, both populations got worse over the period of 45 months. And you see that compared to where they started, both lines go up. However, the patients that were taking Aubagio, that's the gray line, they got more worse than the patients that were on teriflunomide. And you can see the absolute percentages there. The absolute percentages are not very, very big, but that represented a 29% relapse reduction, all right? So that's 29% better than what we get with Aubagio. And this was statistically significant. So interestingly, whereas the relapses were not different, the disability favored taking the favored taking the tolobrutinib, the investigational medicine, in a statistically significant fashion. Now, if instead we ask a different question, if we ask about confirmed disability improvement, this is the opposite of confirmed disability worsening. This is a situation where the person was examined and then sometime later their exam improved. They lost neurological disability. They literally got better and they stayed better for a period of 6 months. Now what you see here is a small percentage of Aubagio patients, 12%, got better, and a small percentage of the tolobrutinib patients got better, but they weren't different. And so we were not able to see that tolobrutinib was able to create more improvement than Aubagio could. The next slide we look at is the MRI. And so everyone in the clinical trials had MRIs rather frequently, actually, and we could compare how many people developed new lesions. And this slide is very surprising to me. The reason it's very surprising to me is what we see is the patients on teriflunomide did better than the patients on the tolobrutinib, on the investigational medicine. So Aubagio, the gray boxes, that's Aubagio that we could prescribe. And what you see is at the end of the trial, there were less enhancing lesions as compared to the study drug. Now, just like with relapses, this is a failure of tolobrutinib to do better on the MRI. And I think a lot of us were very, very surprised by that because Aubagio is a good, not great drug at cleaning up enhancement. And here it outperformed the study drug. This is looking at brain volume loss, and there's a really weird result. Remember that there were 2 trials studying relapsing MS. The Gemini 1 trial, which you see on the left of the screen, and the Gemini 2 trial. And they were identical trials. And in one of the trials, there was a statistically significant improvement in brain volume for the patients that were on tolobrutinib. In the other trial, there was not. So these trials were not consistent. And that just leaves us a little bit confused as to how the drug impacts brain volume as compared to Aubagio. Now, to finish up, it's very important when you look at a clinical trial that you don't just look at the results, you also need to look at the safety profile, because it would be completely inappropriate just to look at the good and not to look at the bad. And so when you take a medicine, there's always risks of side effects, and this is a list of those side effects that you can see. So in the first column, the gray column, that's the Aubagio treated arm. And in the purple column, the second column, that's the study drug. And so as you look down through that, you can look left to right and kind of see what jumps out at you. And the thing that I really, really want to point out is actually on the next slide, and this is liver enzymes. So teriflunomide is processed by your liver. So Aubagio is processed by your liver and sometimes can cause your liver enzymes to spike. Tolobrutinib also can cause liver enzymes to spike. And what we see is that 3 times the upper limit of normal, so that's where the enzymes were 3 times what they were supposed to be, which is very high, was about the same. But as you go over here, we see that the teriflunomide had less of an impact up in the very, very high numbers. I want to direct you to the right where you see 20 times the upper limit of normal. Now, it's very, very rare that BTK inhibitors can cause that severe problem, but it can happen. And so, if you were to take anything away from this discussion, it's that we have to very carefully monitor your liver when you take BTK inhibitors to make sure that we catch these when they spike so that we can take you off the medicine and keep your liver safe. Now, in conclusion, the Gemini trials were negative. They were not successful trials. The goal of the Gemini trials was to see whether or not telobrutinib was better than teriflunomide Aubagio. And what we found was, yes, it reduced disability, but it did not do better with relapses or with contrast-enhancing lesions. So where does that leave us in our thoughts? This result is very, very similar to the result that we got with another BTK inhibitor in relapsing MS. So the Gemini trials looking at telobrutinib, in the Evolve trial, which was looking at evobrutinib in relapsing MS, both were not successful in outperforming Aubagio for relapsing MS. They were not successful in decreasing relapses or new MRI lesions. And so I think that it's going to be unlikely that either of these drugs are going to be used in relapsing MS. However, it is very, very interesting and rather relevant that we were able to show an improvement to disability. And I want you to remember that as we get ready to do the next trial. So I'm now transitioning to a different clinical trial, which was also presented at ECTRIMS. This is the Hercules trial. And the Hercules trial studied secondary progressive MS, not relapsing remitting MS. Now, secondary progressive MS is a situation where a person has multiple sclerosis and has relapses. And they have relapses for a period of time, and then they stop having relapses, and oftentimes they have progression of disability. And so secondary progressive MS without relapses is what we studied with the Hercules trial. And I'll share with you that to date, there are no drugs that have been adequately proven to decrease disability in secondary progressive MS without relapses to any great extent. And so this was a very, very important trial in my opinion. I am an investigator in this trial. And as I mentioned before, I'm only sharing data which is publicly available, so no trade secrets or anything like that. And in this trial, patients who have not had relapses in quite some time, I'll show you the information in a second, were enrolled, and they were randomly assigned to take either telobrutinib, the study drug, or dummy drug, placebo. And so this trial was not compared to Aubagio like the last one. This trial was placebo versus telobrutinib. And it was blinded, meaning the patient didn't know which pill they were on, whether it was a real or a dummy drug. And I, the investigator, didn't know if it was real or dummy drug. And so that was the clinical trial that we embarked in, and I'm excited to share the data with you. So let me get my computer sorted here. So this slide is showing you what's called the baseline demographics or characteristics. So when you put the people in the trial, you randomly assign them to group A or group B, and you do it randomly, like by coin flip. And so this shows you all the people that landed in the first column are on the placebo. They turned out to be on dummy drug. And all the patients in the second column, and I've kind of covered up where it said teriflunomide, I'm sorry for that, or telobrutinib, that's the investigational drug here in the second column. And so you can see that these people were about 49 years of age. And I want to direct your attention where partway down the column where it says time since relapsing symptom onset. These people had had MS on average about 17 and a half years. So they weren't brand newly diagnosed. They had had MS for a while. And if you look just below that where it says time since most recent MRI or most recent relapse, these people had not had relapses in over 7 years. And so again, we're dealing with a population of people that have had MS for a while, and they haven't had relapses in quite some time. Again, highlighting the secondary progressive without relapses. That's the population that we're studying. Now, this slide is the primary outcome measure. This was the big daddy. This is what they were investigating. And what we're looking at here in this graph, as you go from left to right, you get older. So you can see at the bottom it says months 0 through 45. On the right, on the up and down axis, on the y-axis, you see this is looking at confirmed disability worsening or confirmed disability progression. So this is the situation where someone gets worse on their exam and it stays worse for at least 6 months. So at the end of the trial, the patients in gray, you see that gray line, that's the placebo patients. And 37% of them got worse by the end of the trial. If you see the purple line, which is below that, those are the patients that were randomly assigned to take the study drug, tolebrutinib. And a smaller percentage of them became disabled, 27%. Now, you might say, well, gosh, Aaron, that's only like an 11% difference. But in my field of multiple sclerosis, that's a really, really big deal. And the relative risk reduction was 31%. So being on the study drug, you had a 31% chance of having less disability accrual. And that was a highly statistically significant fashion. Now, this result is a really big deal. This result is impressive because we have not been successful in the past slowing pure secondary progressive MS without relapses. And so in counterpoint to the Gemini trials, which was kind of a wah-wah, this trial, the Hercules trial, shares a very, very exciting result. And this is why I put out that post maybe a week or two ago, where I said I was so excited about a breakthrough, because this is a breakthrough. This is the first time that we've been able to do that, and I'm really, really excited about it. Now, on the next slide, and I've kind of covered up the title, this is looking at confirmed disability improvement. So this is the opposite of getting worse over time. This is actually getting better over time. This is your exam improving. And what we see is, compared to placebo, patients were more likely to have improvement on the study drug, and it was highly statistically significant. Now, the absolute numbers were not very high. 5% of the placebo patients got better, and only 10% of the study drug patients got better. But if I asked any one of my patients whether they would like to have a higher percentage chance of improving, they would say, heck yeah, I absolutely would, and I would too. And so the fact that we were able to see that the study drug in secondary progressive MS could decrease worsening and increase getting better is a very consistent and exciting result. Now we're looking at the MRI, and in this trial, we see that the new spots were decreased compared to placebo. Now, in the last trial I showed you, the MRI was not very impressive compared to a Baggio. This is not compared to a drug. This is compared to dummy drug. And so I like seeing that it did a bit better, but it's a head scratcher as far as how we interpret that data. This is looking at brain volume, and this was very disappointing to me. So what we see here, just like in the last trial, is that the drug, tolebrutinib, was not much better at slowing brain volume loss. I was very hopeful that we would see a robust result here, and I'm sad that we don't. I love that we saw disability improvement, but I really wish that we would have seen some atrophy data as well. Now I'm turning to the adverse events, and the table set up in the exact same fashion, where the placebo is that gray column, the first column, and tolebrutinib is the second column, the purple column. And I'll give you a chance to kind of peruse that slide, and you can see left to right some of the differences between the two investigational drugs. The big thing that I think is very, very important to take away is what I showed you before, and that's, again, the liver enzymes. And so what we see here in this trial is that the purple, which is the study drug, was way more likely to cause elevation of liver enzymes compared to a dummy drug, which makes sense. And it also brings out the important part that when you take BTK inhibitors, it is critically important that you monitor liver enzymes. Now, the conclusion from this trial is that we were successful, really for the first time, in slowing disability progression in a secondary progressive population without relapses. And we were also able to show some improvements. We didn't see benefits to some of the other metrics that we were interested in, particularly in brain volume loss, but this is a positive result. And so I appreciate you guys letting me take just a couple short 15 minutes and present that to you. I would love to hear your impressions of these trials. Now, there's a lot more information which will be coming out. This data was not peer reviewed, meaning it has not been reviewed and adjudicated to go into a journal. This is the presentation, but it's still very, very exciting. There's still a lot that we need to learn, but as I interpret this information, I think that we're not as likely to see these medicines used in relapsing MS, at least not this medicine, tolebrutinib. I do think that it's very likely that it's going to find a home treating secondary progressive MS. So do me a favor and share your interpretations and comments of this presentation. Let me know what you think about the Hercules trial studying secondary progressive MS and the Gemini trial studying relapsing MS. And thank you guys for staying with me as I went through all that crazy data. I'm going to switch the screen and we're going to switch back to doing a Q&A, Ask Me Anything Multiple Sclerosis. And I'm going to trade out my coffee for a glass of water. And you know what happens when I grab my water. When I drink, you drink. MS Water Challenge, guys. Ah, that's delicious. Super awesome. So let's jump back into some questions. And this is a question coming off of that presentation from Liz, who says, what's the difference between non-relapsing SPMS and PPMS? That's a very, very appropriate question. So to speak in generalities, someone who has primary progressive MS has not had relapses. Their disease started by slowly getting worse, primarily progressing. Secondary progressive MS, someone originally had relapses, and now they're probably not having relapses, but they're slowly getting worse. And so those are considered two different phenotypes, if you will. I should share with you that there is an ongoing trial that we're participating in at the Boster Center called the Perseus trial. The Perseus trial is studying the same drug, the same BTK inhibitor, tolebrutinib, against placebo. And it's done in PPMS, in primary progressive MS. Now that trial is not ready to have its result read out, and we think we're going to learn about it in a couple short months, probably in about 2 months. So around December timeframe or maybe early January, I hope to get our initial readout about the Perseus trial studying tolebrutinib in PPMS. So stay tuned. And Catherine asked the exact same question, what's on the horizon for PPMS? Well, my fingers are crossed, and I'm very, very hopeful that we're going to see a positive result with the Perseus trial, but we have to wait for the data. Great questions, guys. All right, let's look for some other questions. Looking for some questions in the chat. Throw up your MS questions. So Komuth writes something which I think is true. They write, the younger you are, the more neuroplasticity works. And that's true that younger brains are able to rewire better than older brains. They write, older people have less chance of recovering from the symptoms, unfortunately, but it is possible. And that's true. It's harder to bounce back as you age, chronologically as you get older, but it is still possible. Absolutely. All right, let's look for some other questions. So Laura says, how long before I can switch to tolebrutinib? So it's not prime time yet. I'm literally sharing sort of cutting edge information right as it's coming hot off the press. What has to happen now is they have to submit a package to the American FDA and to the European EMA, and then they have to request approval. And it'll go through a very arduous approval process, and we'll find out whether or not it's in fact approved by regulatory bodies. So if the drug tolebrutinib is approved, let's say, for non-relapsing secondary progressive MS, it's going to be probably well over a year or two before we have a chance to see that. And so it's in the near future. Now, will it be FDA approved? That's to be seen. And will it be covered by insurance? If it's FDA approved, it will be covered by Medicare. And if it's covered by Medicare, it will then be covered by third-party insurance. So stay tuned. Those steps are coming next. So Helen Stone says, how do the BTK inhibitors compare to Ocrevus? And there's actually a BTK inhibitor called fenebrutinib. So fenebrutinib is a BTK inhibitor, which is being compared in primary progressive MS against Ocrevus. And so that's a trial that is ongoing, and I'm very, very eager to see those results. That'll be pretty fantastic when we see it. So let's see, Chad has a question that he's been trying to ask. So let me try to go through and find Chad's question. So Chad writes, hello. Well, hi, Chad. I am currently on Kesimpta. I have been diagnosed with severe MS-related gastroparesis. Do you have any recommendations? So I don't know that the gastroparesis is related to Kesimpta, but I do think that it's something that we see very frequently in MS. So let's talk about gastroparesis and multiple sclerosis. So what is gastroparesis? Paresis means weak or slow. Gastro is talking about your gut motility. Gastroparesis is a situation where you don't move your bowels very fast, where transit of food through your gut is really, really slow. And this can cause constipation. It can cause GI upset. It can make it so that you don't move your food very frequently and that you don't have very frequent bowel movements. And it's actually pretty common in the setting of MS to experience gastroparesis. And so constipation is something that's very, very frequent in my patients and we deal with in clinic all the time. So what can you do about gastroparesis? There's a lot of different things that we can do. And I think that it's important to work with your doctor. There are actually prescription medicines like Linzess, which we can prescribe for gastroparesis. And there's a lot of diet changes, I think, that can help with gastroparesis. So I don't want you just to accept that you have to have gastroparesis. On the contrary, I think there are a host of things that you can do with your neurologist in tandem to try to help get your bowels moving. We spend a lot of energy at the Boster Center for MS trying to figure out how to get people to poop properly. I don't think that that's probably a function of the Kesimpta. Now, one thing just as a complete sidebar, there are some MS medicines which actually can cause diarrhea. And for someone with gastroparesis, sometimes that's a godsend. So I'll take an example of Aubagio. That's a medicine that we talked about because it was used in the Gemini trials against tolebrutinib. And Aubagio is an FDA-approved medicine that I use to treat MS, and it's got a side effect of loose stools. So oftentimes, when I give it to a patient that's constipated, they're actually delighted because they end up having relatively normal bowel movements, which I think is kind of cool. Yep, and Teresa says that constipation is a major enemy in MS, and I completely agree with you. So Liz says, when will the fenebrutinib PPMS data be released? And we're looking at next year. So we're not going to see that anytime over the next couple months. So Linda Schinkel asks, is there an indication for the amount of time someone can be on Ocrevus? So I don't use Ocrevus after death, Linda. So after death, we're not going to treat you with Ocrevus. Pre-death, while you're still alive, we could stay on Ocrevus unless you have attacks on Ocrevus, then we're not going to be very happy with its performance. Unless you have new lesions on your MRI on Ocrevus, because we're not going to be happy with its performance. Unless you get worse on Ocrevus and we're concerned the medicine isn't keeping your disease at bay. If the medicine is no longer tolerated, so let's say you develop Ocrevus-induced colitis, right? That's terrible. Then we might have to stop. Or if the medicine is no longer deemed safe. So if you're having multiple recurrent infections, God forbid, if your IgG level goes really, really low, or if your absolute lymphocyte count goes really, really low, those are situations where we might need to come off Ocrevus. But barring those things, giddy up, we're going to keep on keeping on. And as long as it's keeping your disease boring and there isn't an increased risk, then there's no reason that we would stop. I do not believe that we have to stop at a certain age. I think there are some very fallible neurologists out there that say, oh, if you've reached a certain age, let's say 60, then we have to stop. We don't have to stop, particularly if that person's not having infections and their counts aren't dropping. We're monitoring infection and then we just keep on keeping on. That was a great question. Let's take another one. So this is a very complex question. Valerie asks, she writes, I'm 60 on Ocrevus. My biggest problems are thinking and memory, cognitive issues. I'm no longer working as a nurse because of the stress of trying to juggle tasks. Is there any hope for cognitive issues and attention? So that's a great question. I want to thank you for feeling comfortable asking it. Cognitive impairment, what I call cog fog, is very, very common in the setting of MS. And it's related to fatigue. It's a form of cognitive fatigue. And it's the leading cause of loss of work amongst people with multiple sclerosis. Now, for those of you that are not familiar with the field of nursing, being a nurse is very, very hard. It's a very hard job. The reason it's a hard job is largely because nurses are on their feet. It's a very physically demanding job. Nurses are oftentimes moving human beings in and out of beds and helping position people and doing procedures to people. And so they're up on their feet running around for 10, 12 hours at a time. It's very physically taxing. Also, being a nurse involves a lot of smarts. Nurses are very, very bright women and men. They have to do a lot of math, and they have to calculate medications and flow rates and infusions, and it's very, very involved. And so being a nurse is really hard. And it's particularly hard sometimes to keep up the multitasking and the time pressures in the setting of cognitive effects of multiple sclerosis. Fortunately, there are a host of things that we can do to treat cog fog in MS. And I have a bunch of YouTube videos on this channel where I talk about that. In fact, I have an entire playlist on cognition in MS. Now, if one of the moderators would be willing, I wonder whether you could throw a link to the cognition playlist from the YouTube channel just to make it easy for people to find. While the moderators are looking for that, let me list 10 things that we can do to treat cog fog in multiple sclerosis in no particular order. Number one, we can exercise as part of our lifestyle. Exercise has been shown with good, solid research to improve cognition. And so if you're not exercising, you want to add that in. Number two, making sure that you have outstanding sleep hygiene, that you're getting adequate sleep and quality sleep. So you don't have sleep apnea, we're not having multiple wakings throughout the night to go to the bathroom, you're not being woken up with spasms and spasticity, you're not having restless leg that's keeping you up. We really need to make sure that you get adequate sleep. Number three is cleaning up your diet, and particularly removing sugar and heavily processed foods. That can make a really, really big difference. Number four is treating depression, because if you are clinically depressed and it's not adequately treated, it will make you not think clearly. That's called cog fog, that's called pseudo dementia. So pseudo dementia is a situation where you don't think clearly, but it's not because of a dementing illness. It's because of untreated depression. And when you treat depression, it gets better. So I forget what number we're on. One of the things that we want to do is we want to look at your medication list and make sure that we're removing any naughty medicines, meaning there are medicines that have side effects that can cause cog fog. So for example, oftentimes we will give people medicines with good intentions for their bladder, for spasticity, for pain, for things like that, which have a side effect of making people have fuzzy thinking. I'll give an example, a medicine called Topamax, a medicine that I like very much. It's a seizure medicine. It's a very good seizure medicine. It also is a great medicine to treat neuropathic pain, but in some patients, it can cause cog fog. And so if you're on Topamax and having trouble thinking, we might need to take you off the Topamax to see if we can make that better. What else can we do to help with thinking and memory? We can use medicines to treat thinking and memory. And so I oftentimes will use lotions and potions that we take on the days that we work to trick your brain into being more awake so that you can fare better. These would be things like Adderall or Ritalin. These would be things like, and those are amphetamine salts. These would be things like Provigil and Nuvigil. And those are the ones that I probably use the most to try to improve cognitive function in MS. Another thing that you can do is you can work with a neuropsychologist to do neuropsychometric testing and figure out specifically which parts of thinking and memory are not going well and develop a treatment plan for cognitive rehab. You can go see a speech pathologist, and a speech pathologist is an expert to help with not just speaking and swallowing, but also with cognitive impairments. And you can kind of do physical therapy for your thinking and memory. Now, we've been live now for just an hour. This is our September live stream. My name is Aaron Boster from the Boster Center for Multiple Sclerosis, and I want to thank all of you for having jumped online with me. It's amazing that well over 200 of you toughed it out and participated today, and I want to thank you. If I didn't get to your question, please don't fret. I go through all the questions once the live stream's over, and I pull them out, and I'll answer them in upcoming videos or live streams. As always, thank you for learning about MS with me. If you liked this, please leave a comment in the chat. And the best thing that you could do to help this YouTube channel grow, number one, watch one of the videos on the channel. Number two, share the channel with a friend. We've just crested 75,000 subscribers. That's unbelievable. And I'm now wondering whether we might be able to hit 100,000. I never thought that would be possible, but with your help, it might. So if you have a friend or a family member, a village member that isn't yet turned into this channel, do me a favor and let them know about it. Maybe they'll subscribe. As always, until my next live stream, which we do once a month, or my next Monday video, this is Aaron Boster saying be safe and take care.